Swapnajit, and it's very thanks very much. Thanks very much, Swapnajit, and it's very nice to be back with the group again. And it's very nice to be invited to come and do the the thinking with you, the clinical discussion with you. That's how I'm seeing it. And Swapnajit, what you and I thought is that it might make sense to just go through some of the slides again, but not for too long, so that we have lots of time for clinical thinking, and we will have a role play again. But I really hope, as we started last week, to have lots of clinical discussion. I think that's where the real richness of our thinking comes out, through the questions and answers. And I thought there were some excellent questions last week, and I hope we can come back to some of them. Yeah. So let me share screen.
Yeah, so today's agenda I'll be discussing to the group. Today we'll be first doing a recap of the theory. If anybody new member has joined, can refresh it again. Also, the slides Dr. Tennyson has circulated to me, for anybody can get it so that they can have a revision of the previous classes. And also we will be uploading this in our departmental YouTube channel later after today's workshop. So what Dr. Tennyson will be doing today, we'll be having a brief recap and of the theory and some other materials. So following that, we'll be having again a clinical discussion on the role play and debriefing, and we'll be happy to take all the questions. So it's a good opportunity to learn more about this new type of psychotherapy and how to deal and how to manage patients with borderline personality disorder. And at the end of today's session, we will be having the post-evaluation questionnaire also. That is also equally important. So I'll be telling you all when to fill up the questionnaires. And those who have filled the pre-evaluation questionnaire must definitely fill the post one. But however, those who had not filled the pre, but can also fill the post-evaluation questionnaire. So there is no boundaries, and kindly do the necessary. The link has been shared by Dr. Namita on the group. So thanks, Dr. Namita, and I expect everybody to fill it out at the end. So wait for my instruction when to fill it up, not now. So yes, over to you, Dr. Tennyson Lee. So we will going ahead with it.
Thanks very much, and thanks again to Professor Basu, Dr. Swapnajit, and to Farid Umar for all the organizing, and it's very nice to be again back with the group. So I'm going to share screen now. So, Majid, can you just put up your thumb if you can see the screen?
Yeah, we can see it. It's clear, perfect.
And it moves?
Yeah.
Okay. All right. So the aim of meeting with you over these two workshops is to help us as general psychiatrists to be better prepared for working with borderline patients. And what we'll do today is go through brief lecture, and then go into role play and clinical discussion. But I think what I'll do, I didn't do this last week, but I think it's useful to just think about it now, because I think we understand things better if we place things into context. So I think one of the questions which often comes up is, how is TFP, Transference Focused Psychotherapy, different to a more traditional psychodynamic psychotherapy? So these are some of the differences. That it very much emphasizes object relations theory. It's been manualized and tested, and it's a modified psychoanalytic treatment for treating severe personality disorders. So it really is informed and based on analytic principles, but it's been adapted for working with severe personality disorder. Now, one of the adaptations is that there isn't as much dependence on free association as there is in a more classical analytic treatment. And there's a clear sense in the clinician on what are the steps, or what is the hierarchy of intervention. So it's not as, it's more structured than a traditional analytic treatment. There's a great emphasis on affect, and again, linked to last week, this really shows that the approach that Transference Focused Psychotherapy is taking is very much at the forefront of present thinking about the understanding of the brain and just how important affect is. And again, a difference between a more classical analytic treatment and TFP is that the therapist is more active. They are more prepared to intervene within the session. And another difference is that the therapist is more prepared than in an analytic treatment to be really interested in what the patient is doing in their life, interest in the external world. Now, again, if we now move on to, this is now for therapy. Remember that I'm meeting with you to think of what's the application of TFP principles to our work as general adult psychiatrists or in general psychiatry. So what I'm saying here is these are the aims and objectives of someone in a therapy, not in psychiatry, but this is what I want to think with you as a group. What might be the translation? Which aspects of these might we think are applicable or can we use in our work as general adult psychiatrists? So going back to the aims of Transference Focused Psychotherapy. So this is a patient in a therapeutic, in a therapy treatment, not in a psychiatric, not being seen as psychiatric outpatient, for example. So in TFP, the aim is it's divided into two phases. The first phase is to try to contain all the very chaotic and very behavioral ways that the patient is relating, so the acting out behaviors, and to transform these emotional experiences into thought. That's the aim in phase one. And only once this has been achieved, do we think it's possible to really get to what is the main aim in TFP, which is to help the patient to develop a sense of identity. The main problem in borderline personality disorder is identity diffusion, and it's to help the patient to develop a more coherent sense of their identity. Now, the premise would not be that we as general adult psychiatrists or in general psychiatry can get to this in our psychiatric treatment. But what I want to think with the group today is how much can we try to achieve some of this, trying to get the patient to act out less with us. So again, to go back to Transference Focused Psychotherapy, what are the main elements of it? Again, it's diagnosis specific. The difference between TFP and a more classical analytic treatment, again, is that in TFP, there's the articulation of quite specific treatment goals. Again, a difference between an analytic treatment, a more standard one in TFP, is that there's a clear setting of a contract. And that's one of the great contributions of TFP in clinical work. And again, I'd be very interested in thinking with the group about how might we think of some form of contract in our work with our psychiatric patients. Again, I'm emphasizing here that in TFP, you don't just sit and listen to the patient and sit and sit and sit. There is one thinks about whether the patient is, for example, at risk or breaking the frame of therapy. And those are the points at which one intervenes. One doesn't just let the patient carry on talking if there is, in fact, some intervention which needs to be made because of risk or because of a break to the frame. And as I've said, that in TFP, there's a higher level of therapist activity and a greater attention to what's happening in the patient's external life. So now this is going back to what you will be more familiar with from last week, that what I'm just reminding you that what I said last week is that TFP, think about it as a structural understanding of personality, and then a structured approach to the way we work clinically with personality disorder. So again, the structural approach is if we think of the patient's identity, what kind of defenses they use, how much in contact are they with social reality, what's the quality of their object relations, how aggressive are they, and what's the level of moral functioning. And again, just a reminder that this is a very, very useful chart just to keep as a mental map in one's mind, that when you're with the patient, to think what's the level of personality organization. It's very, very useful to be able to conceptualize the patient in front of me, what is their level of personality organization. And the other take-home message from this is that Kernberg has developed the concept of borderline personality organization, within which he places the more specific psychiatric diagnoses that we think of, for example, borderline personality disorder, antisocial, narcissism, histrionic. So all of these Kernberg would fit in under borderline personality organization. And I want to remind you that Kernberg's depiction of borderline personality organization is a lack of coherence of identity. It's identity diffusion. So you can see all of these, in all of these different more specific diagnoses, the underlying core problem would be a lack of coherence of identity, of sense of self. Now, this is a slide which just shows the usefulness of being able to think about the different aspects of personality and how it maps on to the level of personality organization. So, for example, if we look at identity diffusion, is it present, yes or no? And we'd say in someone with a normal or neurotic personality that there isn't identity diffusion. They have a sense of who they are, whereas someone with a very low level of personality organization, operating at this level over here, the answer is yes, there's a great deal of identity diffusion. Again, if one thinks of what defenses is the patient using, if they're using more mature defense mechanisms, then one would think that they're within the normal level of personality organization. And again, for those of you that have had more experience in psychodynamic work, it's very important to think of the distinction between a neurotic patient and a borderline patient, because a neurotic patient uses a different kind of defense mechanism, and they mainly use repression, whereas with a borderline patient, there is splitting, which is the main mechanism used. And that, in a way, gives an understanding of what is happening in the encounter with a borderline patient, because the difficulty in our work with borderline patients is the great degree of splitting which occurs. Again, if one thinks of the level of reality testing in a normal personality organization or a neurotic one, their reality testing is not poor. Whereas there's a plus as one goes down in terms of poorness of reality testing. So again, you can see the usefulness of starting to think of the level of personality organization. Similarly, the kind of object relations that the patient has, and that the more severe, the more disturbed are the object relations, for example, a great deal of manipulation or exploitation. Similarly with aggression, the lower level of personality organization has more aggression, and similar in terms of problems with lack of morality, again, stronger in a lower level of personality organization. Again, thinking of what are the treatment implications of the different levels of personality organization. Again, this is useful because we as clinicians always think of what's the prognosis. So if we are working with someone that's at a neurotic or a higher level of personality organization, we would think the prognosis is better, whereas clearly we would anticipate a lower prognostic outcome for those at a lower level of personality organization. And again, knowing what the level of personality organization is helps us with, for example, how ambitious can we be in our objectives? So if someone is operating at a very low level of personality organization, we would be less ambitious. And if we can achieve some control of, for example, aggression, we would feel, well, that's a good outcome. Now, still talking about personality structure, what we discussed is that TFP is very much based on the theory of object relations. And in object relations, the components of that, or how one thinks about object relations is it's a dyad. It's a relationship between a representation of oneself and a representation of another bound by an affect. And what I said last week is, if I say the word mother, that immediately makes you think of an object relations dyad. You think of yourself, think of your mother, and the affection or the love you have towards your mother. Now, this is how the theory really starts to take off and becomes dynamic in terms of movement, because if we think of the self and other representation, the individual doesn't stay in the one part of the dyad. There's an oscillation, or there's a movement. In other words, when the patient experiences themselves as the victim, they don't like that. None of us like being the victim, and we reverse the role. We become the persecutor. So there's already the movement, the oscillation at that in the dyad. But then now you can see how TFP really takes off in terms of being trying to track the real movement within a clinical encounter, because one can think there's not just one dyad at work, there are more dyads at work, and that the way that the patient is relating to you might be the surface dyad, and the reason why they relate to you in that very defensive way is it's a defense against some other dyad which may be far more positive, but which may make them more vulnerable in the encounter, and therefore they defend themselves by being, for example, more attacking towards you. Now, this is the way to just have a mental picture of a patient with a borderline personality disorder, that it's a very split personality organization. And in classical analytic terms, this is Melanie Klein's paranoid schizoid position, where, as you can see, that all the negative aspects are put on one side, all the positives on the other. So it's a very split. You know, we often describe our patients as having a very split way of thinking. This is the depiction of the split way of thinking. So now I've just gone through the structural way to think about personality. Structural as in the levels of personality organization, and structural as in the main object relations dyad. And now I'm moving to structured. Structured as in how do we approach our clinical work, and we approach our work in TFP in a very structured manner. So a way that we think about it then is we think of what are the overall strategies, what are our tactics, and what are our techniques in our clinical work with the patient. Now, the overall strategy is really to help the patient. And now I'm talking about TFP. You know, some of this now we can think of how we apply it to our psychiatric work, but I'm still talking about this is the approach in TFP. So in TFP, the overall aim is to help. The overall strategy is in the service of helping the patient to identify their main object relations dyads, because the thinking is once the patient knows, oh, this is how I'm feeling about myself, this is how I'm feeling about the other person, then they can become more conscious of what their behaviors are. So that's everything is in the service of helping the patient identify their object relations dyads. How do we get to do this? One of the main ways that we work is to set the treatment contract in the service, that this treatment contract is a tool for maintaining quite a clear treatment frame. And I'll come back to this more, and I think this will be hopefully one of the main aspects that we discuss as a group. Now, in fact, I'm going to speak more about the contracting now. That in TFP, the reason why we place a great emphasis on the treatment contract is that it allows the therapist to not be as pushed and pulled by the patient as normally occurs in the interaction with the borderline patient. In other words, with our patients, there's often the pressure, do something as of yesterday. You're very slow, you're not giving me the medication, you're not admitting me, all of those pressures. And having a treatment contract or frame in which one works helps the clinician to be more aware of the way that the patient is organizing the clinician's behavior. The treatment contract also lays out what the expectations by the service of the patient is. In other words, we would, for example, say, if you are in treatment, then the expectation is that you attend your therapy sessions. Now, this is something that within my service, so this is my team, this is the building in which we work from, we use the treatment contract extensively because we are a specialist personality disorder service, and it's a vital part of how we work with our patients. So we explain to our patients that they will only be able to start treatment with us if they agree to working with us within the frame of a treatment contract. We explain to them that the reason for working in this way is that because our work is so complex, that it's very easy either for the patient to lose the plot or for us to lose the plot. And the treatment contract is a way that which reminds both parties, this is how we initially agreed to work together. We explain that it's not a legal document, but it is a clinical document. Now, within our service, we've taken the step of actually getting the treatment contract signed. This is an innovation. It's not what most services, TFP services do, but this is what we've done. And we've actually, in that written document, we've identified what are the patient's responsibilities, and also similarly, we'll say what are our responsibilities as a service. Now, hopefully we can take some of this further in our discussion about the treatment contract. So what's the evidence base for contracting? There isn't a huge evidence base, but the little research that has been done has shown that it leads to a lower rate of dropout in patients. Now, again, I'd be very interested in terms of the cultural aspects of this, because within the NHS, one of the problems that we have is because we are a public service provider, at times there is a sense of entitlement on the part of the patient. The patient will think, you are obliged by the state to provide me a service. You just make me better. In other words, there's little sense of, at times, of responsibility of the patient needing to change, for example, aspects of the behavior. And we have found that the use of the treatment contract helps us to try to work with the patient regarding, at times, their sense of entitlement. Again, being a state sector, a public sector service, there's the expectation from our managers and from the public and from society that we would treat every patient that comes to us. And again, use of the treatment contract has given us a better ability when we think there is going to be no clinical gain after extensive trying with the patient to say no, that we won't offer the treatment. Again, just to be absolutely clear that our use of the treatment contract is not as though we use it as a tool in which to punish the patient. So we would use the treatment contract in a way which is trying to understand the difficulty and the limitations of the patient. And this is what I hope that we'll come to in our discussion. How applicable do you think in your work in psychiatry would the concept of the treatment contract be? Because I very much appreciate, I'm speaking from the level of a specialist service, and it would be very innovative work for us to think of what's the application in a more general psychiatry setting. So I'm going back now to the structured approach to working that TFP contributes. And I've discussed strategy, I've discussed tactics, and now I'm coming to technique. And in technique, Otto Kernberg has identified main aspects which is drawn from the whole body of analytic thinking. And his proposition is that if we think of the transference, the countertransference, how one goes about making interpretation and maintaining technical neutrality, then those are the main techniques to keep in mind in the encounter with the patient. So in terms of the transference, and this is a colleague last week, one of the faculty members raised made a very important observation, and I hope that if that colleague is present or if other members of the group heard that comment, I hope we can take it further today, that in the transfer, while the clinician is thinking about what might be happening in the transference, you don't necessarily interpret it to the patient, but it informs you of what may be happening. If it informs you of what may be happening, it at least allows you to understand and feel less confused. But I think a very important point to realize that even in the TFP setting, even in therapy, one makes the interpretation when it makes sense to make the interpretation. One doesn't always rush to make an interpretation. So that's the one main aspect about the coming on to the countertransference. Remember that the countertransference can be defined as the total emotional reaction of the therapist to the patient. And that what we can think of is our total emotional reaction. If, for example, the patient in front of us reminds us of an uncle that we despised in our youth, then we might have our own contribution to how we feel about the patient. So just, as a reminder to ourselves that how we feel about the patient isn't only due to the projection of what the patient feels into us, it may also be our own contribution. So it's not just the projective identification. That's very, very important, because if, for example, some clinicians get to the level they say, I do not like this patient. They must have a personality disorder because I do not like this patient. and that would be an incorrect use of the countertransference. Now, if one thinks of this diagram of the split personality organization, the paranoid schizoid position, this explains projective identification, that no individual would like to have all these negative feelings, and they project it out. They project it out, in this case, we the psychiatrist, into the clinician. And they project it out to a level where at times we might feel, and I hope that within this group that we are experienced and senior enough to acknowledge that at times the feelings we have about a patient is so strong that the term countertransference hate is validly used. In other words, the patient is doing such aggressive and hateful things in the clinical encounter that the clinician feels hatred. It's not to say that the hatred is then acted out on, but if one acknowledges that one actually feels a great deal of aggression towards the patient, it's very helpful, because just that realization helps us as clinicians to act out less. Going on to the other aspects of technique, that within TFP, it's very systematic. In other words, one is not encouraged to go straight into interpretation. And in fact, there are many, many sessions in a TFP therapy in which interpretation is not used. In other words, it's a stepped approach, and one first uses clarification, trying to understand what the situation is, and then confrontation. And confrontation is placed in inverted commas because it's not having an argument with the patient, but it's pointing out to the patient what may be huge contradictions in their views. And then again, technical neutrality is, it's not what the, I think we often make jokes about the, analysts who sort of sit in this very impassive, distant, sort of super clever way and not engage with the patient. This isn't what it means. What it means is the ability to not be drawn into the different parts of the patient's conflicts, is not to identify too strongly with any part of the dyad, but to observe in an empathic way what the patient's conflicts are. And again, this is something which I think is very important in any work with patients with severe personality disorder, and that is to observe what the channels of communication are. So again, if we think of ourselves and what might become clearer in the role play, is can the clinician not just attend to what the patient is saying? Because we as psychiatrists, we train to focus on what is the verbal content. But if we can start thinking, what's the non-verbal and how are we feeling, then we just thicken our understanding, because we're using more channels of communication, not just relying on the verbal. So, colleagues, that was just a quick run through of the slides that we've had before, but the addition was to contextualize it more within Transference Focused Psychotherapy as a treatment on its own, and contextualizing TFP within the wider discipline of psychoanalysis. So that's what I've done now. I think that the way that Maudsley and I thought about it is, at this point, it may be very useful just to open up for discussion or questions and thoughts about the slides before we go into role play. So this is really an invitation to bring in any thoughts that you have now.
Yeah, thank you, Dr. Tennyson, for the very good presentation. It had too much of clarity in understanding the issues with the personality, borderline personality disorder, the importance of therapeutic contract, and how to go ahead. So yeah, I request everybody can just ask any questions at this point of time, because almost all the aspects of the theoretical theory related to transference focused psychotherapy has been covered. So, but there can be various issues which we deal with day-to-day scenario. So you have a very expert person in front of you. You can just ask where you are feeling stuck, how to deal about, and wherever you feel cannot handle, or how to go ahead, you can just ask. Yes. Nishta, you want to ask anything? You if your phone unmuted or mobile unmuted. You want to ask anything, Nishta?
There was a very good question. Is it by Dr. Saini in about the treatment contract?
Yeah. So yes, you can ask directly. What can we do in situation where patient signs off the contract but fails to adhere to it? Is it really on the therapist part or counter transfer that patient is not adhering to their contract? Yeah. Yes.
Let me just read that question again, because it's a very good question. Let me just read it again.
Yes, you can directly ask.
Yes, sir.
Yeah.
Good morning, sir. Good morning, Professor.
Hi,
So my
Hi.
question is, what can we do in situation where the patient has initially signed the contract, but later he or she fails to adhere to it? Is it really on our part, our counter-transference, that the patient is not adhering to the contract?
That's a fantastic question. So thank you very much for asking it. Yeah. Now, can I give an example of one, Yash, and see whether we can, this helps. Say, for example, I see a patient, and I say to the patient, part of the expectation is that you stop self-harming. Yeah. Now the patient might say, "Doctor, I've been self-harming for 10 years. Are you crazy? This is what I do." Yeah. Then my discussion with the patient is, I very much appreciate that this is what you do. Do you think it's a behavior which you want to continue doing? Yeah. And they say, of course, I don't want to keep on doing it, but I can't help it. I just do it because I don't even know that I'm doing it. So I have this discussion, and what I get the agreement on is I say, but you are saying that you would like to not do it. It's very difficult, but you would like to not do it. Yeah? So given that you don't want to do it, my recommendation to you is that you set as a treatment objective to reduce and stop your self-harm. Can you see I'm saying reduce and stop? Yeah. And then I say, but stop it in the time that you're in treatment with me. I don't want you, patient, to say, "Oh, doctor, I will stop it. I will see how much I understand, and at the end of therapy, then I will stop it." That doesn't make sense to me. I want them to do the work in the time that they're in treatment with me. Yeah. Now, then the patient will say, all right, doctor, I agree. If I cut myself after I've agreed, are you going to discharge me? Yeah. And I'll say, no. The more important thing is that you tell me what's happening with you. And if you do cut yourself, then we need to understand what's happening. I'm not going to discharge you. Yeah. if the patient says, oh, if I keep on cutting and cutting, I'll say, well, at some point I might consider discharging if it's just not working. Can you see, I tried to build in that there's flexibility in the treatment contract, but the treatment contract does have consequences, because if it's got no consequences, then no, if you and I make an agreement, and if there's no consequence, you break the agreement, you're not going to respect it, are you? There's got to be some consequence at some point. Yeah. So the other thing to say, and then I'll stop because I think it's such a good question. I want to see what your responses are. The other thing to say, Yash, is that when I say to when the patient, after much negotiation, discussion, agrees to that, I'm not expecting that they're not going to break it, because if the patient has been self-harming all their adult life, how can they just stop it because they've agreed to the treatment contract? It doesn't make sense. Yeah. I'm expecting that they've tried to agree in good faith. That's my expectation. Yeah. And I'm expecting that they'll break it, and that when they break it, that's part of what the work is. Can you see that? I'll say, gosh, patient, you've agreed at the start of treatment that this isn't what you want to keep on doing. But in the last week, you've self-harmed twice. The second time so severely that you had to get medical attention. Yeah. Can we think about what's happening now that's leading you to self-harm when you don't want to self-harm? Can you see that itself becomes what the treatment is? It's thinking about the psychology which is leading to the behavior. Yeah. Does it? Because I think it's a very important question that you're asking. That's why I've tried to think of all the different aspects of it. But Yash, does it address your concerns about it? Do you want to ask more about it, or push the question in a different way? So I'm just handing it back to you because it's such a good question.
Yes, sir. So sometimes in the interview process, suppose we confront the patient, at times the patient doesn't give us time to reflect on. So in such scenarios, how to go about it? Like you told ki, there should be something that you have to draw a line somewhere, and it should be specified. If there would be no consequences, it is bound that patient will not adhere to the contract. So how do we draw? How do we decide that where we have to draw that line? Is it something rigid or flexible?
Look, I think that's a very good technical question. Yeah. Now, I would prefer not to say 3 strikes and you're out, because that in itself leads to an inflexibility. Yeah. So what I say to the patient is, we need to think whether this very dangerous behavior continues, because if it continues, or in fact, if it gets worse, then we need to think, is this treatment helpful to you? And if it's not, then we will discharge you. Can you see how I'm trying to bring in thinking all the time? Because what the borderline patient will do is they will then set up a bit like they'll game you. Yeah. So then they might say, okay, so then I'm going to take a small overdose the third time and I'll see what the doctor does. Are they going to discharge me then? Can you see? So I'm always building in, why I'm building in the consequence. I'm not wanting to myself get into a corner where I have to do something. I want to always be able to think about my decision. Does it address what you're saying? Because I think it's a very good point that you're raising.
Yes, sir. Yes, sir. It surely does. But another thing just came to back of my mind is that suppose we terminate the contract, doesn't it reinforce the patient's belief that earlier belief that even this individual just left me? That fear of abandonment got just reinforced.
Now, I think that that's a really important point. However, I don't want to be a clinician that gets organized by the pathology of the patient so that I do not make what I think is a clinically responsible decision. Within our service, what we've been starting to think is, what is an ethical approach to clinical work? And if after a lot of clinical work, it's showing no good effect, then I, as a doctor, think that I don't want to continue providing the work because it's not helping the patient and it's using public resources. Can you see how? But it's a very, very difficult point. And I absolutely agree with you that that's why I think how we work with our patients needs so much thought, because as you say, it might be a repetition of the trauma. Yeah, absolutely. So I think it's a very important point that you are making, but I don't want to be the clinician that says the patient has had so much rejection that I will be heroic time after time after time because I don't want to reject the patient. I don't want to be that kind of clinician. I will finally say, yes, patient, you might view that I'm rejecting you, but a way to also think about it is that I've been working with you for 3 years. We've discussed this 20 times and you've made this decision. So while you believe that I'm rejecting you, another way to think about it is you're rejecting the form of therapy that I've been offering you. Can you see? And I'm not having an argument. I'm just saying that's another way to view reality. I'm not saying, oh, I'm right, you're wrong. I'm saying, well, that's your view. However, one can also think that there's another way to think about it. Can you see it's, and then that's maintaining neutrality. It's not saying, oh, I'm feeling so defensive, so I'm going to push my point. I'm just saying this is another way to observe it. Yeah, does that make sense?
Yeah, yes, sir, it does. Thank you, sir.
No, these are great questions. Thanks for you asked a deep question, and then I think it's very nice that you sort of started moving around that question. So thanks for addressing that question.
Thank you, sir.
Good morning, sir. I'll ask a question. So since most of us are doing psychotherapy we have not undergone analysis ourselves, and so we may have a lot of unresolved issues and personality issues ourselves. So what I want to ask is how, if we look at Kernberg's model, how do the personality traits of the patient and the doctor kind of interact with each other and affect the kind of transference or countertransference that will be created? Like, is there any way to predict?
Again, that's a really good question. So one of the ways to think about it is that in TFP, we're very interested in the quality of the transference to the clinician. In other words, is it a paranoid one? Because if one can start thinking of what's the nature of the transference to the clinician, that enables the clinician to think of how they usually manage those situations. Can you see that if one knows that one has difficulty in working with a patient that doesn't trust you, then you realize that that's not that you shouldn't work with that patient, just that the patient provides more challenges for you. Yeah, so in other words, one of the answers to you is thinking about what the transference is. Yeah. Now, the other thing is that, okay, I'll say two things. The one is that Kernberg was asked in one of our international conferences, does the TFP therapist have to be in analysis themselves? And that's a very important question, because in psychoanalysis, the answer would be yes, you cannot do psychoanalysis unless you've been analyzed. Yeah. And Kernberg's question was very, very interesting, because he said, gosh, you know, well, this is Kernberg thinking, because he didn't have an absolute answer. So he thought out loud and he said, you know, I've had analysts who've been my colleagues and they don't do very good analysis. And I've had colleagues that haven't been analyzed and they do very good TFP. Can you see how he was thinking out loud? Now, when I'm saying this and when I'm quoting Kernberg, I don't think I or Kernberg were saying one doesn't need analysis. All I'm saying is it isn't the answer to everything. Yeah. And certainly we can think that within our setting as psychiatrists, not everyone has the benefit of going for one's own therapy. So I think it's a very important question. But Eepsita, what I would then say is that it's very important to be supervised by someone who's trained. Because if someone's trained, they can more easily detect if there's something happening in the interaction which is not solely what is being projected into the therapist or the psychiatrist, but something that the psychiatrist might contribute as well. Can you see it's the third perspective, the ability to, and in fact, in my supervision groups, and Farid in one of my supervision groups, what happens sometimes, it's the ability of the fellow supervisees to see it because they're not in the transference. They're not being projected directly. So it's not just the supervisor that can observe it. Sometimes the group can see there's something happening where the patient's pushing your buttons. Yeah. So I think my response is three. You don't have to be in your own therapy yourself because I would always recommend, but you don't have to be. Yeah. Second, to think about the nature of the transference. Yeah. And three, to be in supervision. So those are sort of three responses to what's a very important question.
Thank you, sir. I would just like to follow it up with a thought. Is there something that, if we feel a certain kind of countertransference or the patient evokes certain kind of emotions in us, can we use that as a clue to deciphering what kind of transference is there in play from the patient's part?
So that is exactly the important point that you're making now. Yeah. So, for example, the video that we've got, the training video that we've got is there's a meeting between the psychiatrist and the patient. And the end of the video is that the patient stands up and says to the psychiatrist, you know what, this is a complete waste of time. You've got no idea what you're doing. I've got tablets at home and you'll be in the newspaper tomorrow because I know what I'm going to do with the tablets. Yeah. Now, you and I can absolutely identify with how that psychiatrist will feel. They will feel completely disarmed. They will feel completely helpless at that point in time. Patient is saying, you don't know what you're doing. Patient is walking towards the door and saying, I'm going to kill myself now. Can you see that if the psychiatrist is able to think, a moment ago, I thought that I was managing the situation, and now I feel completely helpless and stupid and blamed, and I've got it wrong. That's the projective identification. Can you see? That's, if you feel that, and you realize that actually you've been doing a competent job, but suddenly your whole mental state has changed, that's a way to think that how I feel is what the patient is feeling, and they don't want to feel it, so they'll project their inability to lead their lives in a productive way into me, and that's what I feel. So it's exactly what you say, yeah, and that's why if one is able to start interrogating one's own countertransference, then that's helpful. If you can't, then you're not using it as data. So it goes back to the channels of communication, and that it's not just what the patient is saying. If one just listens to what the patient is saying, then you might be thinking, oh, that's all correct, yeah, what the patient is saying. But if one starts thinking, this is how I'm feeling, then one gets more in-depth data. It's triangulation of different sources of data. If you're using the verbal, non-verbal, and your counter-transference, at least you've got 3 data points, and therefore you have great ability to think what is happening as opposed to just using 1 data point. So it's absolutely what you say. Eepsita, do you want to follow that up? Because it's a very important question.
I don't have a follow-up question to that one, but I do have another question, which is maybe not very pertinent to the topic, but it just came into my head when you brought up that video where the patient threatens self-harm and leaves. So, and I've also had, I had one patient, a borderline patient who was quite insistent for a very long time that I help her fill out some euthanasia form or something of that sort. So, I mean, in light of the very recent developments of the Dutch woman seeking euthanasia for her mental struggles and that being approved, do you think that it is something that we might encounter more in the coming years? And I wonder if anyone has thought about how to deal with that. People telling psychiatrists that, ending my life is my business and it should not be any of your business. So you should just stop interfering.
So are you saying that what you think about is a scenario where the patient says, it's my right to take my life, so therefore stop interfering? Is that what you're saying?
Yes, sir.
Yeah, yeah. I mean, that you see, the technical point is that I think when the patient says, I am going to kill myself, I think there's something about the clinician realizing that the patient can kill themselves if they want to. There's nothing that we can do. There is a limit to what we can do. So why is the patient coming to the clinician to say, I'm going to kill myself? Can you see there's something which is a contradiction in that they're having the fight with you where they could just go and kill themselves. Yeah? Now, the point, and maybe this is the point about the interpretation. I'm not going to say to the patient, I think the very fact that you are here with me means that you want to live, or part of you wants to live. I won't say that because that might just annoy the patient even more. So, but what I'll be doing is I'll be trying to not immediately respond, but also not allow all the pressure of what the patient might be trying to project into me is, you convince me to stay alive. That might be what the pressure is. And, to open up an argument about that. So I think I'll be trying to think, how am I feeling at this point in time? I'm feeling a great urge to enter into a debate with the patient about the need to protect life. I'm also feeling, oh gosh, I don't know all of the different laws about. Can you see? I'm starting to think of how am I feeling when the patient raises all of this, and then I might use it to think some of how I'm feeling, maybe my own contribution, because in truth I don't know all the regulations. But it's not only my own contribution, it's what the patient's projecting into me. They don't know what to do, and they're projecting their uncertainty into me. And maybe also in a way which is humane, then thinking, this is what they wish. They wish that I would be able to provide them with a magical answer. Can you see how one starts thinking about all those things? So I haven't answered you directly in terms of but I think I'm trying to think of what's the psychology of what's happening, both in terms of my own uncertainty about what to do, and in terms of why is the patient doing what they are doing at present? Does that sort of at least start giving you some way to think about how the clinician might think? And I think it's easier for me to say it because the patient is in front of me and they haven't just asked a question right there where I wasn't expecting it. So, I appreciate that in the actual situation, it might be even more difficult to think of how to position oneself. I think that's what a lot of this workshop is about. It's about how does one position oneself in an impossible situation? I think that's partly what it is.
Thank you, sir. I'm regretting asking it now because I now think I could have used it in the role play.
Now you've given me a clue.
Now I can't use it anymore. Thank you, sir.
Okay, so anybody else who can ask?
I just had a couple of comments and a question.
Yeah.
So Dr. Tennyson, just you're talking about the NHS, the way that it's set up, and the sort of entitlement that patients have because it's a public service and they, feel like they're entitled to care and all of that. I wanted to lay some context because PGI is a public service hospital as well. So the difference is we don't have an appointment system in PGI. And so any patient that comes to the OPD is seen the same day. No matter how many patients, so it can be 400 in a single day, and they are all seen. So it just made me wonder about the way that the NHS is set up, and there's so many hurdles to seeing a psychiatrist. You have to first see your GP, then see a psychiatrist, and then if you are sort of deemed ready for psychotherapy, then you are referred, and then if you have a long waiting time. So I just feel like the difference in the presentation, the initial presentation of a borderline patient coming into therapy or into a psychiatrist's office in the NHS in the UK is quite different to that in India, because when they're already quite frustrated, they feel persecuted, they feel like they're going to be abandoned right off the bat when they come into treatment in the UK because of all the hurdles they've had to sort of go through to get there. They immediately quite hostile, and the defenses that they that are activated, the object relations, all of that is quite different. But in India, just the way that doctors are perceived and the respect that's there for doctors, and the accessibility, all of that influences the therapeutic relationship. So I think that's just something that came to mind to be aware of, that eventually I feel like all patients will present the same as therapy progresses or contact with the doctor continues for a certain period of time, but just the initial presentation I feel like is quite different.
Marie, can I make a quick response to that? And please do bring in the other points. In terms of what you've just said now, I think it's such an important point, because I trained in South Africa, and in my first ward round in the UK, I thought, my word, what a defensive way of working this is. That the UK is so concerned about patient complaints that I think it organizes how it works. The reason why I'm saying this is that if we think that TFP was invented in New York, and although Kernberg's team does work in public sector, they also work a lot in private sector. I think this is a very interesting point that you're raising, because I think within this group, we can also think which aspects of the clinical thinking around TFP might be very culturally related. I think your point that finally, if the patient settles in, a borderline is a borderline. I think we shouldn't say that it's culturally specific. But I think there's something that you are saying about how there may be certain ways that the clinician or that TFP has been set up due to its Western context and due to the different services, where we shouldn't just say, oh, well, this is what it is. I think we should think of what might be, in terms of the basic mechanics, which seem to make sense, what might be different ways to think about it. So I just really want to think it's a very important point that you are raising.
So shall we go ahead with the role play after a short break?
So, what I wonder is, should we have the short break now,
Yeah.
and then go into role play? Does that make sense?
Yeah.
Sure. How long would you like us to break for?
You let us know, sir.
should we break for 10 minutes and then
Yeah.
so we'll start again in 10 minutes time then.
Yeah, sure.
That's great. All right, see you all shortly. Bye.
Yeah. So I welcome you back. So, we'll be proceeding ahead with today's role play session, and as you remember from the last session of role play, so we will be having going ahead with the same patient. If everybody could remember, it was patient Nina who presented to the emergency services after medication overdose, and she presented to the doctor for the first time. And by the end of the session, it was observed that she agreed for subsequent follow-ups and tried to change herself and come for the next follow-up. So, and today she has followed up for the next time with the same doctor. So, and now she has waited patiently today for her turn, and she entered the room, and here we start the role play.
Um, My name is Nina. So I'm glad that actually we are able to meet again, and I'm wondering how you are compared to when we met last week.
Hello, doctor. It's nice to see you, but I mean, of course, I haven't taken any more pills, but I'm not doing so good.
Well, that's important to hear that you haven't taken pills, but also really important that you've been able to say that you're not feeling so good. So I think that's what may be helpful for us to think about today then, how you are today, and what it is that's making you not feel so good.
I don't know. I just think nobody loves me. I just feel very alone, and that's what I think. If what's the point of putting myself through all of this if nobody loves me? I mean, treating me can't make people love me.
When you're saying this, is it in particular, are you thinking in particular about the relationship with your husband?
Yes, but even before that, boyfriends before him, my teachers, my college professors, my colleagues, nobody seems to like me very much. So I think that's why I try to off myself so many times, because I think the world might just be better off without me.
Well, I'm glad that you've brought in what's so important about this feeling, that you have, that people don't love you. But just to go back to what you just said now, I just want to check in with you. And I do want to get back into what I think is so important about feeling loved. But at present, do you have you been having any more thoughts about wanting to harm yourself?
I would say the thoughts are pretty much always there, and they've always been there since as long as I can remember. But I think some days I'm just able to push them back further down, and some days I don't have control on them. So I do have thoughts, but I haven't done anything like
So it seems that if it's correct that that isn't the main thing in your mind, because at times that might be the most pressing thing. But if it's not the most pressing thing, then should we think about what you've said about relationships?
I hate to interrupt you, doctor. Can you just tell me again, like, why are we doing this? What is the purpose of this? Why am I seeing you?
So I think I think that's important to think about. I'm seeing you because, luckily enough, I was able to see you in outpatients after the emergency department, and I'm seeing you to see how you are compared to last week, but also how we may be able to take things forward with you. So when you say that you have concerns about your relationship, that seems very important. I think what's also important to think is that we may not be able to, well, we won't be able to sort it out in this meeting, but it's important just to see where you are so that we can think together about what might be a way, what might be a sensible plan to try to help, but it won't be a quick thing.
Okay. Okay. About what you asked, yeah, we can talk about my relationship, but like I said, I don't think it's the relationship per se. I mean, that's part of it, but I, I don't think I've ever had a good relationship in my life with anybody, not just romantically. And sometimes I think it's me, I'm the problematic one, and I every doctor, every therapy, it's like you do this, you do that, and it's ridiculous. I mean, if it was so easy to do this or do that, I know what I should be doing, but it's not possible for me to do it.
Well, you've taken the thinking quite far already. So can I just ask you, because you've taken it so far, and also to say that when you say, you can't just make the change. I would understand that, but what is it that you've thought in the past that you would need to change if it was possible?
Just just losing my cool, uh,
Mhm.
losing control of my emotions, and
Mm.
doing stuff that sometimes I later think about and regret. Like I look back and I wish I hadn't done that, but
Mm.
it's already too late by then.
So, I think we get into the heart of the matter now. It's very important. Is there some something which is an example of what you've said that will really give me the best way to understand what's in your mind when you say that you do things that you afterwards wish that you hadn't done?
I At my last job, I was working as an assistant to a manager in an office, and I got along really well with him. Like,
Mhm.
for the first time, I felt like an employer really understood me, and he was extremely mindful of my uh, uh, the fact that I had anxiety, and he would be really sensitive to that, and that made me work better, and I worked really well.
Mm.
And this one time, and I had the freedom to just walk into his office, and he would be very open to that. And this one time in the morning, I walked into his office, and I was in a really good mood, and there was this there was this new recruit in his office, and she was this young pretty thing, and he was they were talking and laughing, and I just felt as if I had walked in onto something.
Mm.
And when I walked in, they just kind of stopped and they stared at me, and the managers he said, maybe Nina, maybe you can come back in some time, I'm a little busy right now. And I cannot tell you, I felt so much of anger. I felt like there was bile rising up inside of me, and I was positively shaking with anger. I was just so angry. And I couldn't even tell why. I try to calm myself down. I try to because at that time I remember I was seeing some other doctor, and I remembered he told me to take myself out of the situation and try to calm down. And I did. I tried to calm myself down, but it just wouldn't go away. And I just got angrier and angrier, and I don't know how, but I ended up breaking this glass vase that was on my desk, and I just threw it at his door, and it caused a huge scene. And of course, I got fired. And
Mm.
for the next few days, I was pretty angry, but also I was satisfied with myself because I felt like he deserved it, and I didn't think I had done anything wrong. But yeah, now when I look back at it, it was a nice job. It was a nice employer, and I don't know. I don't know why I reacted like that, and uh, sometimes I do wish I hadn't done that.
Well, you see, what you're saying is very important because you've in fact taken it quite far, because what you've said is there's something which you did, which I think we can understand, but the fact that you did it, you now feel, gosh, you overreacted. Is that correct?
Yeah, maybe. I mean, I don't think it was all my fault, but yeah, maybe I could have not broken the vase, I mean, I could have been angry quietly without letting people know.
Yeah, and even before we think more about that, what I'm understanding is that you got on very well with your boss. That was a good relationship, and that you valued it.
Yes, that's true.
Yeah. And what I'm thinking is that at the time when you went into the office, you were probably, just looking forward to seeing him, having, some important exchange, and that because you were feeling, so looking forward to seeing him, because it was a good relationship, that you then felt very disappointed when you saw him with the other colleague.
Yes, and he and I shared such a good relationship, and we knew each other for 3 years at that point. And she was a new hire. I mean, she hadn't been there 3 days.
Hmm.
So I don't see what was so important that they had to talk about that they had to send me out of the room.
Yeah, yeah. But that's what I'm thinking, that you were very keen, you were looking forward to seeing him because he's been an important, and you've got on so well at work, and it was very disappointing, his response to you. That's what you're saying.
Yes.
Now, I think what you're saying is really important, and there are two things I want to do. The one is to think with you about if you were in therapy, how do you feel that we might be able to help you, or the therapist would be able to help you? And then the other thing I want to ask you is, what you've just said now, does it happen, with, say, family or in your other relationships? Or maybe let's go to the first question, and that is, how do you feel you would like to be helped regarding this?
If I had the answer to how I would like to be helped, I would have treated myself by now, wouldn't I have? Like I said, it's the same experience, do this, do that, this technique, that technique, calm yourself, take a walk, use a stress ball, something. And while in the moment they seem like good ideas, but when I'm in that situation, I don't know. I'm so overcome with what's going on. I can't bring myself to do any of those inane things. So I think how I would like to be helped is, be the professional, fix me instead of telling me what to do.
Well, yeah, but I think I said the wrong thing there, because in a way, I asked you something which is maybe you're thinking, well, why should I know? Because I'm not the professional. So I take your point. Let me just change the question a bit, and that is, am I understanding it correct that what you would like to do is to be able to not get into that very strong outburst with your boss? Is that correct?
Yeah, I mean, I don't know. Help me so that, next time I'm in the situation like that, I don't react that way.
Yeah. And as you say, how we get to it will be, it's not as though you need to have all, or you can have all the answers, because you would, if you come into a therapy service, you would be the patient, and also you know all of that. So I take your point. Let me just ask you though, do you feel that with help, you would be able to change that kind of behavior?
I honestly don't know. If I'm being honest, maybe not, because I've just tried and failed so many times before. But I don't know. I think there's a part of me that's still hopeful that maybe something, maybe this will be the one, this one will be where I make the big change.
So that's important, that, partly what I'm hearing you say is, you're not being, so you're saying, yes, I will, but you're saying that maybe there's a small possibility that you could make the change. Is that what you are saying?
Yes, maybe.
No, that's very important. And then the other thing is, and again, I very much take your point that I'm not asking you now as a professional, and that the professional's work will be to work alongside you to help you to make these changes. But what my question is whose responsibility do you think it will be finally that you're able to change and take things forward?
You're just like the rest of them, aren't you? I mean, you want me to say at this point that it's my responsibility. And maybe it is, maybe it isn't, but it's not just mine, it's everybody else's too. It's on other people too, to not be complete morons with me all the time. To not keep pissing me off all the time, just like you did right now.
Well, I take I take that point of view, but again, can I just take it a bit further with you about this? Because I appreciate this is I can take what you're saying, but can I just ask it again in a way? Or is that okay that I can?
Yeah, okay, go ahead.
If you were in therapy with a therapist, then while you are saying that you as a patient will want some help and support, I think my question is finally, do you think it's going to be you or the therapist that will be the main person that makes the change?
Yeah, okay, I see what you mean. It will be me that makes the change, obviously. But I don't think, I mean, I think I need the therapist to be really effective in helping me make that change, and not just kind of be, instructional like a manual or a book, and actually effect change in me.
That seems a very fair point that you're making. Now, let me just pause here and see whether you have any thoughts or questions that you want to bring in now? Because we've discussed a lot of important things.
Are we still in role play?
Yeah, we are.
How do you mean? Could you rephrase your question? I didn't quite get
Sure.
that.
You know, we've discussed such important things now, and I really want to acknowledge that in a way you're really taking the thinking forward. What I want to ask is, just because we've discussed so many things, I don't want to rush it. Are there any things you want to go back on or to clarify or to ask?
I do have one question.
Hmm.
Are there other people like me, or do you think that I'm an absolute freak? And I mean, do you see other people like me?
You see, what you've described is that you say in interaction with your boss that this was an important relationship, and that the upset that you had when you saw him with the new colleague is because it's such an important relationship, and what you feel is that you acted too much in a way. Now that is what I've heard with many other patients in the past, that kind of strong reaction.
रस्सी गिल आ रहा है हमारे
Do they get better?
रस्सी गिल
Well, you see, where we are in this meeting now is I'm the psychiatrist trying to work out the best way to understand you. If I haven't finished my assessment, but I'm starting to get a sense of what your difficulties are. And if I'm correct, and as I say, I'll need a bit more time, if I'm correct with the diagnosis, then the answer is there is very, very good treatment for it. But it goes back to my question of whether you feel that you're able to do some of the work, because the successful treatment is when there's a good working between both the therapist and the patient. In other words, therapist helps, but it's also a lot of work by the patient. So I've given you quite a complicated answer, but does it make sense what I've said?
What kind of work do you want me to do?
The work that the therapist would want you to do is to think about the behaviors that you think aren't helpful. That you think, not me, because you've said you don't want people to tell you what to do. And to focus on those so that we can think of the psychology of what's happening when you do those behaviors. That's what the work is.
Okay. Okay,
So,
I can do that.
so let's stop role play now, and then we can debrief. Yeah. So, Swapna, do you want to take over the chair now?
Yeah, I would say that this was much better. It's actually looked like a real therapeutic scenario, and thanks, Eepsita. You really played very well. And you were definitely a very good actor also. Yeah.
Well, Eepsita, we need to get you onto Netflix, I think.
Yeah. Yeah. Thanks. So yeah, so anybody who want to comment anything? So I want to ask the resident what was actually going on in this session. Could anybody take a lead and try to explain? Anybody? I think it will be very starting from the senior resident, because they have a little much more experience than the junior residents or the trainees. So I would like to ask from the senior resident first. And it's very important that how to analyze it, because such scenarios also come in our day-to-day clinical practice. So yeah, anybody, senior resident? Yeah, go ahead. Don't feel shy, and it's your session. So we just, anybody. Well, Prasant, Raj Lakshmi, Namita, whoever they are. Just, there is nothing right or wrong. You just have to say. Nobody is going to judge anybody. So just speak up what all you could feel, what went in the session.
Hopefully I'm audible, sir. My net connection is not really good.
Yeah, you are audible.
Yeah. So what I did come across here is there were a lot of fluctuations that the patient did go through in the entire single session. She was bouncing off between being on the same side as the therapist and then again going against the therapist. And I could see sir was able to capture her in maybe is this what is neutrality, or I'm not really sure, but he was able to maintain his stance throughout the interview, which was very constant. So the therapist could always find him back when she could come back, and there was always a point of agreement that I could see in the conversations. And the conversation was somewhere aimed together to come into this common agreement where mutually there is a decision of working together at the end of the day. And that's something which I could really appreciate. Secondly, often here in this conversation, we could see the patient was often on the brink of breaking down. And one of the things that I was going through is we are often tempted to console the patient in between. We stop in between and say, it's all right, it's not a problem. Or we just stay silent and think if this is an awkward silence. So I just need some inputs into how do we handle those breakdowns in between.
I think it's a very important question technically. Eepsita, I don't know if you want to make any response to that, because I do think that, as Val was saying, that you went through different emotional fluctuations, didn't you? And also then how you experienced me responding or not responding. So do you want to address that? And I also will come in after you.
Yes. First of all, I'll just say that both those things were very intentionally done. The fluctuation also, because I think that's it's about the paradox of the borderline patient, right? I mean, seeking help and denying help at the same time. So, I want to be here, I want help, but at the same time, I don't want you to tell me what to do. So yes, and of course, I mean, I think the emotional fluctuation was maybe not there that much, but this was definitely there. And yeah, the breaking down, yes, in my experience also, the at times, okay, in this case, the patient or that is me, just like it was the crying was pretty unintrusive, so it was not really, I mean, hindering the conversation. But sometimes people will have very full blown no breakdowns, and at that time, I think it's very human to want to console the person in front of you, but I think to not do that is what training is about. And to kind of like in dynamic terms, maintain that holding environment for the patient, and not jump into or get sucked into the patient's emotional vortex, so to speak.
Yeah.
I think what Eepsita is saying is really important, and in a way, I think it informed my thinking that I can see the patient's upset, I can see that she's using, but I don't want to rush in and say, I don't want to be over sympathetic. Yeah, I want to provide a setting where she feels I'm a kind clinician, but I'm not over involved. Can you see there's something about, so at times it's the ability of the clinician to also not say something immediately and to not feel it's being punishing either, because you're just trying to think really. But in the silence, you may be able to convey that you're not unconcerned. It's you just, you know what it's like sometimes with the child and the mother, that if the mother is too solicitous, too caring, it winds up the child a bit more even. Yeah. And
Yes.
so sometimes it's useful that the mother just gives the child a bit of space, but they are showing that they're there and they're interested, but they're not rushing in, nor are they too distant. So it's that neutrality again, just trying to be present without being too concerned that you don't know what to do at that time. But
Is there an element of nonverbal communication that we should be aware in this point of time?
You see, what I'm all the time, I'm thinking of how's the patient responding to me. So I'm aware that I haven't commented on the patient crying. Yeah, I haven't said you're very upset. Yeah.
Yeah.
But I'm testing that, because if I feel the patient becomes even more upset, then I might say, look, I'm very aware that you've had gone through so much. When I saw you last week, things were very, very difficult. Can you see? Then I'm starting to become a bit more supportive. Yeah. By checking what the, in other words, if I notice that the patient is either becoming more tearful or seems to be becoming irritable, or there's a change in the tone, or there's a fidget or something, I might think, actually, I now need to do something to adjust myself to try to provide more of a setting. Can you see? So you're just observing us all the time, really.
Right.
But the thing is, you need to trust your own feelings. In other words, if I was thinking, I need to say something, I need to say something, I need to say something, I might be thinking, is it just what the patient's projecting into me, and I shouldn't necessarily respond immediately? Can you see? So it's trying to work out all the time, and that's why I work as a psychiatrist, so complex, because there's a lot of decision making we need to do very quickly in a way. And you can see that with the other thing is, when Eepsita says, you know, in the very good role playing, it's always like this. You always expect, you don't tell us what to do. You say, what should we do? I'm not the professional. What I'm saying, I didn't expect it at that point in time. And then it's to roll with the punch. In other words, to say, that's a very valid point. In other words, it's not having an argument. When the patient pushes, at times you just move a bit back, yeah, to see whether they can feel that you're not having a fight with them, except, you know, validate where it seems reasonable, yeah, so that you're trying to help them all the time to regain their ability to think in a way. You see how it's
Right. There was also this moment where I think you had to, maybe more than once, you had to ask a permission to, you know, rephrase your question. And there was also a point I do remember where you had admitted I was wrong. And is it okay to say that and even apologize, or do we go to an extent and sorry for asking that question? Are we allowed to do that?
You see, as long as, I think when you say, are we allowed to, I think what we should do is try to be straightforward with the patient. I think that's useful. Yeah. And that as long as I feel I'm not apologizing because the patient has forced me to apologize, as long as I think there is something valid in that, and that I'm then not such an insecure clinician to say, actually, maybe I didn't ask it in the most helpful way. Can I just try it again? Can you see then? It's particularly with the borderline patient, but with the narcissistic patient, it's also important, because the narcissist will always say, they will always want to think they're right, you're wrong, and that you're lower than them. So sometimes it helps when you can say, that's a very good point. It allows them to be a bit less defensive and just to take in a bit what you're saying. Yeah, so what I'm saying is, I'm not saying it as a technical point. You just do it because what I'm saying is, but if you do it in a sincere way, it does help the process.
I think I'd just like to add to that. as the patient, I think I was coming from a place of where I have kind of tried to back people into a corner in most of my relationships. So it leads to the point where either they say sorry, or they fight with me, confront me. So I think I was pushing the therapist to do the same. And what was refreshing for me as a patient was I felt validated without without the therapist also, kind of saying that I'm wrong. At no point did he say that I'm wrong or apologize. He just kind of, okay, maybe I didn't say it in a way that you understood it, or maybe I didn't say, maybe I can say it in a different way that would make more sense to you. So I think walking that tightrope is key, perhaps.
Because to add on to what Eepsita is saying, remember what we are saying, it's very complex. It's very difficult for the patient to understand anyway, because it's a complex thing that we're saying. It's very difficult conversation. And then the other thing which makes it even more difficult is being faced with reality. In other words, our role as doctors is to discuss what's happening. And the patient doesn't want that. So it's very, very complex for the patient to take it in, which is why it's useful that we always try to lower their defense so they can process the information a bit better. And you see, it's being very mindful that it's very difficult to take it in. You know, Belle, if you meet with your friend and your friend has a different point of view to yours, it's difficult to process it because it isn't what you expected. It's difficult for human beings, I'm saying. So it's just being mindful that it's a very difficult thing, and therefore being, in a way, quite humble about saying, can I just say it again? Because I think I didn't get it across. You know, it's that ability to just try to work with the patient in that way.
Yeah, that makes sense. Thank you, sir.
Okay, so may I now request all the participants to fill up the post-evaluation questionnaire, and in the meantime, we'll be taking 2 more questions. So all those who are attending, I have circulated the link to Namita. Namita, you can put up the link again in the resident WhatsApp group or in the WhatsApp group of our department so that everybody can fill it.
Yes, sir.
Okay. So in the meantime, I would like to take feedback from any junior resident who would like to give some feedback. So many junior residents attending, so feel free to discuss, because there are such patients you will be seeing in the coming years in your residency. So any junior resident?
Yes, sir. So I have a few points to make. Just a few observations that during most of the conversation, what Dr. Lee tried to do was that he was paraphrasing to better understand what the patient was saying. There was a lot of validation and silence at appropriate places. But confrontation was used in the last part of the interview, more of that. So was it done on purpose? And whenever the patient tried to push in, the therapist took a step back and again went ahead with a slightly related question. And what I could decipher from the entire conversation, that it was not just that the primary issue initially with which the conversation was opened, that was not directly addressed, but it was somewhat addressed. Like the conversation started that the patient being bad at relationship, but it was addressed somewhere in the vicinity. And just the last thing for Dr. Eepsita, did the dyad which Dr. Lee earlier talked about, that there's a hidden dyad did that became evident to her, like being cared for as a child and the perfect provider, and there is a aspect is longing and love.
Okay, so I'll just answer first. So first, I think I'll step out of my bounds and answer what you had asked for Dr. Lee also, that the purpose, the definition of psychotherapy involves on purpose or done purposely, right? So I think everything that the therapist is doing is done on purpose. Nothing is by chance. And I think if the dyad became evident to the patient, the patient would not be a patient anymore, right? I mean, if the patient could understand, okay, I am feeling like a child that being cared for, and uh, I'm transferring my feelings for my mother onto the therapist. I think maybe that probably occurs on some unconscious level, and maybe in a later session, perhaps, maybe not in the initial one, but I may be wrong about that because I'm not very sure about. So I think, yeah, maybe the dyad did as the patient I felt it, but I don't think I don't think the patient would be able to kind of name it in that sense that this is a dyad or this is how I'm feeling.
Eepsita, I just want to build on what you've said, because a lot of what you're saying is so helpful. You can see that, Yash, from what Eepsita is saying, that the therapist might know what's going on, but he doesn't necessarily say it. Can you see? Because it goes back to technique, that if you have an interpretation, you don't always say it. If it's not going to help the patient at that point in time, you don't say it. Yeah. So in other words, I think the way that I would think about what Eepsita is saying is that even if the therapist is aware that how the patient is relating to me might be related to their early experience where they didn't have trustworthy parents, I wouldn't say it to her, because it doesn't make sense to say it at that point. It's just, it'll sound as though I'm being too clever. Can you see the point? But I can be informed by maybe the way the patient is so suspicious of me is because of her early experience. And then that just helps me to not feel too irritated. Why do you not trust me? I'm the doctor. Can you see? It's just informing the way that I can think about what's happening. Yeah. But I just want to respond to some of the other issues that you've raised. The one is, you said that towards the end there was some confrontation. I think that that's important, because if one, for example, I think partly what I was saying is, in a gentle way, look, which behaviors do you want to change? Yeah. That might have been. Now, the thing is, I'm not saying it as in having a fight, but nor do I want to spend my time with the patient just listening to why her life is so bad. That's a waste of time. That then would just be supportive, letting the patient ventilate. It doesn't help. Yeah. So what I'm saying is, I'm prepared in a manner which I hope is tactful and gentle to say, okay, how can I help you now? Yeah. Let's not just go on and on about how dreadful life is. Can you see? But I'm not doing it in an impatient way. I'm trying to, yeah, that's the one. The other thing that I hope that you can also appreciate is, I say to the patient, look, do you think even a little that you're able to make these changes? Yeah. Because the reason why I'm saying that is, it's a TFP principle that if the patient doesn't believe they have agency, then they're not offered TFP. They can go to some other treatment, but they don't get TFP. Yeah? Can you see how? And I'm not expecting that the patient is, oh, yes, I can. I'm not expecting confidence, but I am expecting even 0.1% ability to think they have agency. 0.1% I will accept. Can you see my point about this? But if there's zero agency, then there's no work, because TFP is very practical. It's about, what do you want to change? Yeah? And if the patient, oh, I don't think I can, you tell me, doctor, you help me to, then I wouldn't take them on for TFP, maybe some other kind of treatment, but not TFP. Yeah. And then I also asked the other question, which I could see wound up the patient, about responsibility. But I will ask that question because that's TFP as well. TFP expects agency, even if it's very, very small, the expectation that the patient believes that they can make the change, and responsibility, that it's not my role as therapist to make the change. It's my role to help you, but ultimately it's your role to be responsible for the change. So I try to get that across as being what's very important in a TFP treatment. Some of the other treatments don't expect that. TFP expects agency and responsibility. And then the other thing, and it's partly related to your question, you can see that I said, can you give me some example which will really help me to understand? I want specification. Yeah? In other words, if the patient just says, oh, everybody doesn't understand me, I just get into bad tempers, I don't know what's happening. So I want a clear example. Yeah. And what I want to say about what I get out of the clear example is I get that the patient really wants a good relationship with the boss. And that, can you see that I emphasized to her, look, when you went into the office, you were really looking forward to the meeting with him. Yeah. Because what I'm trying to do is I'm trying to make her not feel humiliated about her getting angry. I'm saying it's so understandable. You got so angry because you really were looking forward to it. I'm emphasizing the libidinal part of the diet. Can you see when I do that? But I can only do that if I've got specification. What was the actual incident? Otherwise, I can't do that. So I'm showing you the advantage of getting specification of the, of the actual kind of behavior that she does. Yeah. And then the other thing is, again, it goes back to the point about interpretation, that we've said one doesn't always interpret. Yeah? And even in a psychotherapy session, one doesn't always interpret. But I think even more so in psychiatry, because what I'm thinking is that, remember that I was role-playing with Eepsita, the situation in psychiatry, not in therapy. Yeah. And that if I started to say as a psychiatrist, look, I think the way you relate to me is due to your early experience, I think I don't think that's really the most important role for the psychiatrist. I think the role of the psychiatrist is to help the patient along their way into a therapy at this point in time. Can you see? So it's always to think of what's the function, what's the main task of seeing the patient in your present setting. And I think that my function wasn't to be a therapist, it was to be a psychiatrist, to try to help the patient along the journey into a therapy. Can you see it's being very clear about what the task is that you're in? For example, if you actually are providing the therapy, then it's a different task. But what I was role playing was just being the psychiatrist, but not being the therapist. Does that make sense?
Yes, sir.
So we are towards the end. I think the participants are less now. So I request Dr. Basu, if he is there. Sir, can you give some of the concluding comments so that we wind up? Or before that, I need to ask our faculty members who are there till now, Dr. Rana, Dr. Salini, Dr. Ritu, if they want to give some comments.
Sure, sir. Today's, I think, was a well-rounded, we got an idea of what transference focused psychotherapy is, and the role play was very interesting. I particularly congratulate Dr. Eepsita for her acting prowess, and also there are a lot of techniques to learn is what I gathered from Professor Tennyson today. I could really appreciate during the role play how, sir, you have facilitated reflective thinking in her by providing reality testing each time when she challenged, and also letting her own up to the therapy process and letting her set up the goal for the therapy each time while she pushed you to decide for her therapy goals, how you have actually very gently taken it, steered the whole conversation. And even in the face of being challenged, maintaining neutrality, it really seemed difficult to imagine. Myself as an interviewer, I was thinking, oh my God, what do I do? I would have really paused for a very long time to figure out and gather. But truly appreciate, sir. You've inspired me, and I really appreciate this. Thank you.
Thank you. Yes, I go ahead to ask Dr. Basu to say some words about the workshop, how it went, and give his views.
Yeah, thank you. Thank you very much, Swapnajit. It's been a pleasure being a silent part, but nonetheless a part of this two-part series, and preceded by Dr. Kambui's talk. So this was quite a journey, I would say, and actually you wish that that we had more of this, because obviously probably having 2 sessions wasn't enough, but I think it was pretty good enough as a curtain raiser, or at least talking about an overview of the various issues involved. And excellent talk by Dr. Lee. It was both the last one and this one. Today it was especially the reiteration of the main points which was covered in the last session. That really helped. At least that helped me to buttress some of the points, because some of these tend to get lost. So I think today the things were definitely clearer, more nuanced, and of course, as has been already said, that this role play on both the days, and particularly today, helped to clarify and to discuss upon a number of concepts which are important in the day-to-day clinical issues. I just wish that our students, and including us, actually all of us, learned from this such effort, and for which I can't thank enough Tennyson, certainly, but also Swapnajit for from our side for organizing and coordinating this entire exercise. And we benefit from this, and we plan to take it further. And I think our coordination and collaboration would continue, or at least I very strongly wish so. Thank you very much, Tennyson, for helping us and guiding us through this. Thanks a lot. Thank you.
Thank you, sir. So again, I would like to request all the residents who have not yet filled up the post-evaluation questionnaire. It is there, so you can fill it up today, and the responses will be recorded. So don't miss to fill it up. And again, I thank Dr. Tennyson from the bottom of our heart on behalf of all the residents and all the faculty members from the Department of Psychiatry, PGI, Chandigarh. Thank you, sir, for taking all the pains for teaching us about this very important psychotherapy, part of psychotherapy on the patients with borderline personality disorder. Thank you. Thank you so much.
So I just want to say thanks to Debashish, Swapnajit, Farid. It's been very nice to meet with your group. I think the questions have been excellent. I think it really demonstrates the depth of your clinical team, really, because they've really pushed the envelope. They've been really, I think it's really tested thinking around TFP. So thank you for the very, it's been very stimulating. I also want to thank Eepsita. Thank you. I mean, the workshop is partly it's based on how good the clinical thinking is, and your role play really helped us to push our clinical thinking. So really to thank you for that.
Thank you.
Thank you, Eepsita, and thank you, Farid, for coordinating for this. Thank you. And at the last, I would like to thank all the residents who joined, and I hope you had learned some of the clinical skills. Yeah, sir.
Well, I just wanted to thank Farid again. I had forgotten, and it was very nice to see him after a number of years. And and gratifying to see that he has not changed an inch. Great to see you, Fareed, and hopefully we'll keep in touch again. Yeah, okay. Thank you. Thank you.
So goodbye, everybody. Thank you.
Thank you. Thank you.
Everyone.